Right. Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great. And today we're going to talk about COPD, one of the most commonly tested topic in licensing exam. Very common, right? Can you guys see it? No? Let me share the screen. You guys can see it now? Good. All right. So today we're going to talk about COPD. So asthma and COPD is very commonly tested, very commonly. Like I have never seen any MCQ1 exam that it did not have any question from asthma or COPD. So always in the licensing exam, regardless of which country are you preparing for licensing exam, COPD and asthma is going to be very commonly tested. All right. So today we're going to discuss about COPD and how to go about it, how to diagnose it, how to manage it, and how to do the differential diagnose, and what are the complications that we need to look out for. And at the end, I'm going to give you like 10 to 20 points that is essential to know before you attempt the real exam, because those are going to be in the exam and you cannot miss them. So as long as you know that those like 10 to 20 points, you don't have to worry about the COPD. Okay. So let's start with what to expect on the exam. Exam common COPD question style would be confirm the diagnosis. Like how do you confirm the diagnosis? So obviously we have to know about the definition, like what is the COPD, which they're not going to ask you about that, but we have to understand it, which I'm going to give you guys the definition in the next slide. But how do you confirm it? How to diagnose it? So spirometry, it has to be like on the top of your list. Some IMGs, um, I'm not gonna like mention some IMG. It's a common mistake. Usually, when they see the patient has cough or sputum and stuff, then they usually go after the imaging. So COPD, if you're highly suspicious of COPD, do the spirometry. Avoid imaging unless the COPD is complicated, okay? Or you want to rule out pneumonia, or you want to rule out something very vital like pulmonary emboli. Other than that, don't do the imaging. Just spirometry is the confirmatory. Choose the maintenance inhaler based on the symptom and exacerbation risk. So, how we start the treatment, how to maintain the patient on a proper regimen of the treatment, and what are the inhalers at what specific time do we have to add it. So I think I did make a stepwise approach in terms of management for the COPD, and I believe that you guys have access to it. If you go to Jala Note in your account, you should be able to see it right at the end of the COPD notes. And then the management of acute exacerbation of COPD. What is the oxygen target? Like this one you cannot forget. Like I have seen it in so many question bank. Most commonly tested. Why? Because it is very vital to know the range of the oxygen that you need to target for the COPD. Because if you go beyond that, you might cause the patient life. You may cause damage to the patient lung, and eventually the patient may die. So that's very important, 88 to 92%. So that should be your target. We will talk about it in the next slides. So bronchodilator, obviously we have to start it with bronchodilator and then we have to step it up. And until it is not responding, then we have to start the oral medication. And also for the antibiotic and steroid, there is a stepwise approach when we can start it, at what time should we stop it, and also what kind of antibiotic is the best choice for the treatment, what antibiotic is the best choice for the prophylaxis, and what are the second or the third choices antibiotic for the COPD. And identifying the mimics. Like there are some conditions that they mimic the clinical picture of the COPD that we have to rule out, like pulmonary emboli, pneumonia, pneumothorax, congestive heart failure, that they happen to be also the complication. Prevention, the best and most important thing that we need to know, smoking cessation. Other is vaccination. Another one is pulmonary rehabilitation and long-term oxygen therapy. And we need to know everything about all these points that I'm mentioning. So high yield decision points, post bronchodilator, the FEV1 over FVC threshold, that is something that you need to know in order to be able to diagnose the COPD or differential diagnose between COPD and asthma. If it is less than 7.0, then it is definitely COPD. So when to add a steroid and when not to add it, and what are the times that we have to like step it down or taper it down to prevent another condition. Oxygen targets to prevent from the CO2 retainer, which I did mention that you need to keep it between 88 to 92%. Very important. Please remember and memorize this. 88 to 92%. That should be your target. An indication for non-invasive ventilation if the patient has hypercapnia and acidosis. Hypercapnia, like the PO2 is above 45, but the pH is less than 7.35. If you have these two, you have to start the NIV or non-invasive ventilation. Antibiotic trigger, in the scenario, if it is mentioned Prulence, then you have to start the antibiotic. The long-term oxygen therapy criteria, we will talk about it. There are some indication for it. So in terms of definition, as I mentioned before, that it's good to know, but it's not going to be in the licensing exam, obviously. Progressive and irreversible condition of the lung characterized by chronic obstruction to airflow, with many patients having periodic exacerbation, gas trapping, lung hyperinflation, and at the end stage, weight loss. So in terms of diagnose, as I mentioned before, if you have a patient who has characteristic finding of COPD, now you are trying to do a differential between asthma and COPD, or you want to confirm it, then you go ahead and start doing the spirometry. Before you do that, you give the patient the bronchodilator, you check it, and then if this FEV1 over FVC is less than 0.70, then it is confirmed COPD. If it is above that, it means the patient is improving. If the patient is improving, asthma. If the patient is not improving, it means it is COPD. So exam traps to avoid, things that you need to avoid because they will test you on that. So can support phenotype, like for this chest X-ray and CT scan, it will help you to find out about the types or the phenotype of the COPD or the complication, for example, for pneumonia. For pneumonia, it's hard to diagnose it with spirometry, right? For that, obviously, you have to use the chest X-ray. Or, for example, you have pulmonary emboli. For that, you have to do the CT scan. Other than that, don't do imaging. Spirometry is it. That's it. Okay, does not confirm the COPD. Remember, it is not confirming. It's not going to use for the supporting the diagnosis. It's just not used because we have a spirometry for the confirmation, unless you want to go after the complication or the phenotype. Always use post bronchodilator values to avoid labeling asthma as COPD, which we do. Use FEV1 percentage to predict for severity. So this one is used for severity once you have the diagnosis. Remember that FEV1 over FVC, we use it to confirm the diagnosis. But FEV1 This is used after the diagnosis. Once you have the diagnosis, now you're going after the severity of the COPD, then you go after this one, or you check it with this one. And commonly used in the uh, like medical area or by healthcare providers, commonly used. There is a fine trick between FEV1 and other techniques, which I'm going to explain it, that you need to be very careful in terms of wording the question. But treat based on the symptom and exacerbation. Phenotype and physiology. So basically, these two, the chronic bronchitis and emphysema, they can overlap. Sometimes it could be, both of them could be positive at the same time. They could overlap. And in terms of definition, the chronic bronchitis, productive cough most days for more than 3 months per year for 2 consecutive years. Mechanism is mucus hypersecretion plus airway wall thickening and luminal narrowing. So the typical clue that they use in the scenario, they will give you a scenario about someone that who has history of COPD and the patient has chronic sputum and the patient has chronic cough for more than 2 years, for more than 3 months, 3 months or more than 3 months per year for 2 consecutive years. That is a clue. Obviously, the patient will have wheezing, and very, very important points that they want and expect you to know to differential diagnose between emphysema and chronic bronchitis is the DLCO. DLCO is usually or often normal in bronchitis, but it is lower in emphysema. And please remember this, that's why I made it red, because it will be in the exam. I'm not saying 100%, most commonly tested. They want you to, they expect you to know how to differentiate between, because sometimes the symptoms are overlapping, right? So it's very hard to differentiate. But how do you differentiate? With DLCO. If it is low, emphysema. If it is normal, bronchitis. So exam risk, think airway disease, treat with a bronchodilator and prevention bundle. Now, emphysema. It is destruction. Emphysema is destruction. That's why the DLC goes down. So it is destruction of distal air space with a loss of alveolar wall. So the mechanism, elasticity goes down, or elastic recoil goes down, dynamic airway collapses, and air trapping. That's why when air trapping happens, hyperinflation happens and the barrel chest. So typical clue, again, they will give you a clinical picture of somebody who has COPD and then dyspnea, hyperinflation, and DLC is low. And usually they will complicate it to pneumothorax. And emphysema, in terms of emphysema, usually it, comparing to chronic bronchitis, if this is positive, usually it will be in younger age. When I say younger age, I don't mean like 10, 12, 11, 40, 45, less than 40 or 45 years of age. And usually they may have or may not have history of smoking as opposed to bronchitis. Or they might be a smoker, but very mildly here and there, occasionally, but still they have COPD, as opposed to chronic bronchitis, which usually the smoking will be the main risk factor. So in this case, if they are young, there's no history or a mild history of smoking, then go after the alpha-1 antitrypsin deficiency. Check it. So this is a picture. I think you should be having it in your notes. So basically, for the chronic bronchitis, B, blue blotter. So the patient is usually a little bit cyanotic. Comparing to this one, the patient will be pink, pursed lip, and 10. Risk factor and targeted workup. So what MCQ1 expect you to recognize quickly? Quickly, very important. For COPD, there will be usually smoking positive in the history. Again, if it is not positive or if the patient is not heavily a smoker, then think about alpha 1 antitrypsin deficiency. Okay. And exposure to like wood, smoke, and so on and so forth, occupational dust, chemical, air pollution, and host factor. Usually, in terms of age, COPD is usually happening in elderly above 45. It is less than 45, then think about the risk factor, think about alpha 1 antitrypsin deficiency, childhood respiratory infection, low socioeconomic status. When to test alpha 1 antitrypsin again. So COPD emphysema at the younger age, when I say younger, it means less than 45 to 50. Disease severity out of proportion to smoking, it means the patient is severely sick, but when you check the history or social history, the patient is not a smoker or the patient is a smoker. Very occasionally, like only on weekends, he is smoking with friends. Family history of early emphysema, a bacillus predominant emphysema pattern, action order, the alpha 1 antitrypsin level, and refer to confirmatory test for if it's low. Now, assess what matters for the treatment. Symptoms plus exacerbation drive decision. So, core assessment, the symptoms burden, and the CAT and MMRC, exacerbation history, past 12 months, number, severity, hospitalization. They do matter. Like you have to, like if you're doing Nakoski and you are dealing with a patient who is suffering from COPD, you need to know the numbers of the exacerbation, the severity, and number of hospitalization. Why? Because it does matter in terms of mapping out your management plan. Because you need to have a lot of stuff if the patient has frequent ER visit or frequent hospitalization. Smoke status, inhaler technique, adherence, same thing like asthma. So the patient has to, the first best or even the step zero, they call it step zero. It means it's not even a step one, it's a step zero. This should be on top of your head. Like you have to stop smoking because the most common reason or risk factor for the COPD is smoking, and you need to know how to go about it. And if you are practicing Nakoski in this case, I think most of you, so you need to know the start, the mnemonic start, which I'm going to show you guys, like how to set up a proper plan for smoke cessation. And then you go about the inhaler and teach the patient how to use the inhaler in a proper way. And adherence. Adherence is another factor that most of the patient that they come with an exacerbation of asthma and COPD, they are not adherent or compliant with their medication. Comorbidity, CHF, CAD, and OSA or obstructive sleep apnea, anxiety, depression. Consider phenotype clues, chronic. We did talk about it. Prognosis, very high yield. Strongest predictor is frequency, severity of exacerbation. The both, we will discuss it. Index, which is focusing on BMI, FEV1 for severity, and MRC, and 6 minutes walk. Red flag, chronic hypoxemia, hypercapnia, pulmonal is the red flag. Exam move if dyspnea is this proportionate. Look for the mimics or comorbidities. All right, so a stable COPD and medication pathway. Start with bronchodilator and then add anti-inflammatory therapy only when indicated. So we do use this anti-inflammatory drug if the patient the patient is basically moving on to bronchitis and there's a frequent exacerbation, then you can add the anti-inflammatory medication. So step one, start long-acting bronchodilator, LAMA or LABA. So SABA is always there. Remember, SABA is not considered the first line. It is zero. It's zero line. So like it is always there. It's always there, but it's PRN, like as needed. The first step to start the real treatment is LABA or LAMA. If it doesn't help, then LABA or LAMA change to LABA and LAMA. I hope it makes sense. So for the first stage, you're choosing between LABA and LAMA. But in second step, you combine them together. So it is LABA and LAMA. And third stage, since it's called third stage, it will be triple therapy. So LABA, LAMA, steroid. LABA, LAMA, and steroid. So zero step is short acting. That is always there. So that's why it's not even considered as first step. They have to have it always in their pocket. They use it as they need it. But the treatment is LABA or LAMA, one either or. You can start with either or, which in most cases you start with LABA. So LABA and or LAMA. But if it doesn't help or the patient's symptom is not improving, then you combine them together. Now, in step 2, you have two medication or two inhaler, LABA, LAMA. And third, now you have LABA, LAMA, and steroid. Do not use a steroid alone. If there is an option that it says ICS monotherapy, don't even think about it. Just ignore it. It is not the right option. Okay, that's why I made it red. So avoid a few things. I wrote it down here and red. ICS monotherapy. Like if you see it and if you're dealing with a COPD patient and the options A, B, C, D, E, and you see ICS monotherapy, don't even look at it. That's not the answer. Like take it out. Why? Because it increases. First of all, we never use it as a monotherapy. It's not the first line of therapy. And we never use it as a monotherapy for what reason? Because it increased the risk of pneumonia. Okay. And not only we don't use it as a monotherapy, we don't use it for a long term. And that's the main reason that it increased the risk of pneumonia. And maintenance oral steroid. Don't use it, especially if it is mentioned monotherapy. Why we don't use it? Because of obvious reason, because it comes with a lot of side effects. But if you have a steroid, oral steroid, and it's only for 5 days, which is the typical duration for the steroid for COPD, that is your answer. 5 days. 5 days. Maintenance is long term, so it means that you have to keep taking it for a long time. That's not your answer. Routine theophylline. This medication is outdated nowadays. Like they are not preferring to use it for obvious reason. It causes a lot of issue in the heart. It causes tremor and so on and so forth. Foundation that move outcomes. The MCQ1 expect prevention and longitudinal care. So smoking cessation again. Now, if you are practicing Nagoski, the first and most important thing that you need to know in terms of treatment is what to go after, and that will be the smoking cessation. Smoking cessation. Most effective intervention to slow progression. Combine counseling plus pharmacotherapy. Remember, if the smoking cessation, the patient has already tried it and he has tried it so many times and he has failed, which in most cases, the patient with COPD or any other health condition, they will come and they will complain that they have already tried quitting, but they failed miserably. And the reason that they fail is because they don't have a proper structure. They don't have a proper management plan. That's why they start and they fail. If they go about this quitting in a proper way, in a healthy way, in a best or healthy structured way that's designed for them, they will definitely succeed. And I'm going to go about it and tell you guys the mnemonic and also explain it. But our job as a healthcare provider, when we do the consultation for the COPD, or especially there might be one Or maybe you have a station that you have a COPD, then counseling the smoking cessation together. It's a combo. Or you might only have one station that's consultation about somebody who has COPD and wants to stop smoking. And then you have to go about the smoking cessation strategy. Now, if you have somebody who had COPD and he has tried it so many times and he failed it, now you have to start the structure and the treatment at the same time. Treatment for smoking cessation. And you might get two different questions. What is the best first treatment for smoking cessation? It will be nicotine. If they're asking you what is the best choice, it will be Chimpax or Varenicline. Okay, pay attention to the wording. If they're asking you what's the best first treatment or pharmacological treatment of smoking cessation, it's always nicotine. If they're asking you the best choice, it will be Varenicline or Chimpax. Bupropion is also considered one of the good medication that helps with the smoking cessation, but it comes uh, a little bit more with the side effect comparing to varenicline, and varenicline has shown to be more effective than bupropion. Now, again, in Nakoski, you have to do the STAR. In the next slide, I'm going to show you. Vaccination. So the first is always what? Smoking cessation. The second one is vaccination. So vaccination, you will definitely, when it comes to prevention, they will test you on vaccination about influenza and pneumonia. Okay, so remember these two. Reduce pneumonia and severe respiratory illness review at every chronic disease visit. Now, pulmonary rehabilitation, improve dyspnea and exercise capacity considered after hospitalization for a high symptom burden. Remember, they might ask you after hospitalization, what is the best preventive treatment? Pulmonary rehabilitation includes supervised exercise, education, self-management, and this and that. So post exposure, remember post exacerbation rehabilitation within 2 weeks if possible. Within 2 weeks. This, please remember it. Now, smoking cessation, there is a mnemonic that's called STAR, S-T-A-R, STAR, S-T-A-R. S, set a quit date. Like you have to choose a date for yourself. Like this is the date that I'm going to stop it. It doesn't have to be right now. First, before you want to do it, you have to plan it. And you can plan it with your family doctor. If you're a family doctor, then you have to talk to or consult with your patient and then plan it. Okay, now set a date. What is the date? Let's say in 2 weeks. In 2 weeks, it's 1st of January. So write it down and put it on the, or stick it right in front of you somewhere that is always visible, for example, in the fridge. So pick a specific date soon and commit. Let's say you picked the date and it's 1st of January and you stick it on the fridge and it's always visible and it will remind you that that's the date that you have to start. And then T stands for tell friends and family. Like you have to let know everybody that you're quitting, you're deciding to quit smoking. Why? Because if you have a family member who is also happen to be a smoker, he or she shouldn't be smoking in front of you because it is, when you have somebody that who is smoking in front of you, it's very hard not to smoke because you're craving for it, right? At the same time, the person is smoking in front of you and he is kind of like pushing you and encouraging you, come on, just one step, let's do it. And then you change your mind and start smoking. So you have to let them know that this is your plan and you would really appreciate if they do not smoke in front of you. So that is also out of the way. Now, anticipate the withdrawal. They have to be prepared for the things that's coming, the withdrawal symptoms that's coming, and he has to be prepared himself. So even though that he is taking medication, the withdrawal will come, but it's not going to be as intense as uh, in the time that they are not using the medication. So that They will still experience it, but not with the same intensity while they are not taking the medication. So they have to anticipate that the craving will be always there, irritability will be, not always for the few weeks, and it will always happen. Poor sleep plan, and yeah, stuff like this. They have to be prepared for it. And or remove anything that reminds you of the smoking, whether it is the lighter, whether it is the ashtray, whatever that reminds you of smoking, you have to remove it. Now you have this strategy, which is called the STAR, and then you have the medication, varenicline, and then you should be good. And usually you start the medication before you start quitting. You start the medication while you're smoking, because if you're smoking or using like 20 cigarettes per day, so when you start the medication, the number of the smoking will drop significantly. It will drop to like, let's say 5 to 10, and slowly it will be 2. You don't feel like smoking, and then you slowly stop it. And usually when they complain that I tried to quit and I failed because they were not taking medication. Long-term oxygen therapy. Now, this is very important. I want you guys to memorize this. You have no other choice. You have to memorize this. Let me make it red because this might be in the exam. So for long-term oxygen therapy or home oxygen therapy, the PaO2 is supposed to be less than 55. If it is less than 55, you have to start it. But it can be more than that, like 56 to 59. You still can start it if the patient has cor pulmonale and polycythemia. Okay? So it's supposed to be less than 55 to start the home oxygen or long-term oxygen therapy. But for people who has polycythemia cor pulmonale, it can be even a little higher than 55, 56 to 59. Use more than 15 or more than 15 hours per day for mortality benefits. So exam notes, do not prescribe long-term oxygen therapy based on the transient hypoxia during an exacerbation. Reassess when stable. After optimization, oxygen for dyspnea without hypoxia has limited benefit. So as you guys remember, when I started the asthma and COPD in general, I mentioned that we usually give oxygen when the patient is hypoxic. We don't give oxygen if the patient is not hypoxic. And when it comes to COPD specifically or exclusively about COPD, we are not going to be very aggressive in terms of oxygen therapy. Why? Because if you go really crazy about oxygen therapy, then you cause the CO2 retention or poisonous, or we call it hypercapnia respiratory failure, right? So you need to be very cautious when you're giving oxygen to COPD patient. The target is between 88 to 92%. The complication of the chronic hypoxia, secondary polycythemia, pulmonary hypertension, and core pulmonary right heart failure. So this one we did talk, right? Acute exacerbation of COPD. So the definition, sustained worsening. When we say sustained worsening, it means for 48 or more than 48 hours of dyspnea, cough, or remember, the sputum is and or. So these two, if you have a patient, the patient has COPD, but in the last 2 days, the patient coughing is getting worse. Dyspnea is getting worse. And or sputum is getting worse or more, or smelly. Then in that case, it is exacerbation. So you have COPD, but in the last 48 hours, it is getting worse. When I say it is getting worse, either it is it is the cough, and it's the dyspnea, and or the sputum. So these three, but remember, even if you don't have the sputum, these two, which is the cough and dyspnea, is getting worse, you still have the exacerbation. And if you have the sputum and it's purulent, antibiotic is indicated. So sputum increase in terms of amount, in terms of smell, and becomes purulent. It is an indication for antibiotic. And what antibiotic is the best choice? Amoxiclav. Okay. So yeah, I think I did mention this. Common triggers: viral upper respiratory tract infection, bacterial infection, air pollution, CHF, pulmonary emboli, and MI, which are the mimics. Always ask, is this really the exacerbation? So this is very, very important points of the COPD. Because if you have a COPD, always when the patient comes to the emergency room, we always expect that this should be exacerbation of COPD, right? But we have to be very cautious, not to forget about very vital conditions that if you miss, the patient will die. For example, pulmonary emboli. Because pulmonary emboli comes with the same clinical feature of exacerbation. A few difference. For example, the patient might have pleuritic chest pain and also might have tachycardia, right? See, COPD usually happens in elderly, right? And pulmonary emboli is also happening in elderly. So it means if somebody who has COPD comes to the emergency room and he's getting worse, he has dyspnea, he has cough, we have to rule out the very deadly conditions like pulmonary emboli, like pneumonia. All these conditions that they are very dangerous, we have to rule them out, then it is exacerbation. I hope it makes sense. Okay. So red flag alternate pleuritic chest pain, focal crackles. See, focal crackles and fever, if it is focal crackles and pleuritic chest pain, and or for example unilateral finding, chest pressure or edema, then it is not exacerbation unless I rule out all other conditions. For example, if the patient has new edema, I have to rule out the heart failure. If it is not heart failure, then it is exacerbation. If it is unilateral finding, if I have unilateral, or for example, right side or left side, there's no breathing sound, and when I check in the percussion, there's hyperresonance, it is pneumothorax. If it is not pneumothorax, then yeah, it could be exacerbation. Or if it is a focal crackle, then it's pneumonia. If it is not pneumonia because the patient has fever, then yes, it could be what? Exacerbation. Or pleuritic chest pain, it could be pulmonary emboli. If it is not, when I ruled it out, then it is exacerbation. As opposed to diagnosing COPD. For diagnosing COPD, you don't have to do all these unless the patient is meeting all the criteria. But for exacerbation, you have to rule out the deadly conditions: CHF, pulmonary edema, pneumonia, and pneumothorax. Test example. For example, if you're suspecting pneumonia, for example, if the patient has fever, crackles, I would do chest x-ray, anterior posterior, to find if it is pneumonia. Or if the patient has tachycardia and pleuritic pain, then I have to do CT angiography to make sure it is not pulmonary edema. And same thing. Treatment bundle, simple algorithm. You can exclude under time pressure. Very important. The first hour that you encounter with a COPD patient, ABC, monitor vitals, consider ABG, VBG, if severe or altered. So usually we don't do this unless the patient the patient condition is severe, or the patient has altered mental status. And oxygen, again, I made it red. Please memorize this: 88 to 92%. Otherwise, if CO2 retention risk, otherwise it causes the retention, CO2 retention. Bronchodilator, SABA is always there. Ipatropin bromide, MDI, spacer, or NIP. Systemic steroid, prednisone, usually around 40 milligram. Remember, 5 days, not for maintenance, for long term. If they want to test you on a steroid, oral steroid, they will test you like not how much. They are not going to ask you about the dosage, but for how long. That will be a question. That might be a question. Antibiotic for purulent sputum, which I did mention it before. Escalate when needed. So I use the NIV or non-invasive ventilation by PAP if my patient is hypercapnic acidosis. Hypercapnic is like PO2 is more than 45. More than 45. In some cases, it will be even 70. So anything above 45, but the pH is low. The pH is less than 7.35. If it is the pH is less than 7.35 and PO2 is more than 45, then I have hypercapnia and acidosis, which is uh, representing or showing that the patient has hypercapnic respiratory failure. And I have to escalate it to NIV. And if this fails, the next option will be intubation. Remember, the intubation is coming right after the NIV. Unless the patient is like collapsing, then in that case, you have to do intubation. ICU if the life-threatening exacerbation or ventilatory failure after stabilization, optimize maintenance therapy and arrange rehab, document an action plan. That is part of the NACOSC. So in terms of non-invasive ventilation versus intubation, exacerbation with elevated PaCO2 and acidosis, persistent severe dyspnea with a sign of ventilatory. The goal is to improve ventilation, reduce the work of the breathing, avoid intubation. And why we do NIV? To avoid intubation. Why? Because intubation is aggressive. It is invasive. Reassess early clinical plus gas exchange. So now intubation or bypass NIV, inability to protect the airway, severe decreased consciousness, hemodynamically instability, refractory hypoxemia, or if the NIV failed, that the next step is the intubation. Copious secretion or inability to tolerate the mask interface, prepare for the post-intubation ventilatory strategy, avoid dynamic hyperinflation. So this is the difference between non-invasive ventilation and intubation, which you guys should have it in your note. If not, let me know. I will add it. So now the red flags differential. Pulmonary emboli, I think I did mention it before. These are the things that when you are dealing with COPD, they have to be like all around your head and it should be right in front of your face that you have to rule them out, okay? Like pulmonary emboli, pleuritic chest pain, tachycardia, minimal sputum change, action, rest, stratify, consider D-dimer, no, just go with a CT pulmonary angiography, which is most commonly used and the best investigation. Pneumonia, the patient will have fever, focal crackles, and toxicity. Chest X-ray, treat as community-acquired pneumonia, not just exacerbation. Pneumothorax, they include sudden unilateral pleuritic pain, decreased breath sound, and hyperresonance. Action, urgent image, and decompression if unstable. CHF, MI, clue, orthopnea, edema, chest pressure, new crackles, action, ECG, troponin, chest X-ray, diuresis, ACS pathway, as indicated. We have already talked about them. Now, for the complications, I made a mnemonic that is a little bit easy and fun to remember. So I made COPD blows. COPD blows. C stands for cor pulmonar. O stands for oxygen low, like chronic hypoxemia. And P stands for pulmonary hypertension. D stands for drop into exacerbation. B stands for Boley burst, pneumothorax. And L for lots of CO2, hypercapnia, respiratory failure. And O, overgrowth of RBC, secondary polycythemia, which is the cause of chronic hypoxemia. Weight loss, cachexia in the later stage, especially in emphysema. And S for sick chest infection, pneumonia, recurrent infection. Select add-ons an advanced option. So add-on for frequent exacerbation. Roflumilast is if you have chronic bronchitis. Remember, you have COPD, and the COPD phenotype is bronchitis, chronic bronchitis, plus severe obstruction and frequent exacerbation. If you have that, then this is going to be a best choice. Usually, if they want to test you on this one, they will give you a scenario about someone that who has COPD and the patient is taking LABA. Obviously, the SABA is there, LABA, LAMA, and now the patient is having like 3 exacerbation, so it's frequent, and the patient phenotype is bronchitis, or the patient has chronic productive cough for 2 or more than 2 years, and the patient has dyspnea. So in that case, this could be the best add-on medication. Azithromycin prophylaxis. So if you guys remember, I said for the antibiotic, they might ask you what is the best choice treatment antibiotic, or they might ask you what is the best choice antibiotic prophylaxis. So if they're asking you the best choice treatment, amoxiclav. If they're asking you the best choice prophylaxis, it will be azithromycin. So select patients monitor the QT and hearing resistant risk. So these are very important. Why? Because azithromycin causes those issues. Azithromycin prophylaxis can reduce exacerbation frequency in carefully selected COPD patient with a frequent exacerbation, despite optimized inhaled therapy and risk factor modification. So for this one, they will give you a scenario about someone who has COPD. He's very compliant with the medication. You have started the step 1, didn't help. Step 2 didn't help. Step 3 didn't help. The patient stopped smoking, didn't help. The patient stopped pulmonary rehabilitation, did not help. Now for this patient who had not only compliance to medication, he did all the preventive measures, which was quitting smoking, which was rehabilitation, getting the vaccination, and the patient is still worsening. Not only that, the patient had frequent visit to ER. Now for this patient, we can start azithromycin as a prophylaxis. Okay? Keep that in mind. This is not used for everyone. This is a specific condition. They might give you a scenario like this, and then this would be the answer. Now, for the lung volume reduction, select heterogeneous emphysema. Remember, for this medication, remember chronic bronchitis. For roflumilast, right? For this one, chronic bronchitis. For lung volume reduction, remember emphysema, heterogeneous emphysema, and hyperinflation that is not improving with all the treatment, or all optimized treatment has exhausted. Now I have to go after the surgical or procedure that helps improve the symptom, which is the lung volume reduction. If that doesn't help, or if they mention the patient is an end-stage COPD, if they mention end-stage COPD, that is a good indication for transplant. If you see this word, your answer is transplantation. Refractory dyspnea, consider low-dose opioids. This one is a little bit tricky. Refractory dyspnea. We all know the benzodiazepine, we all know the opioids, they are causing what? Center respiratory depression. So if it does, then why am I using opioids? Remember, if they want to test you on opioids, they give you a scenario about somebody that all the treatment has exhausted and the patient does not want to go to do the surgery. And now it is planned to do a palliative treatment. It means the patient is going to die. Sooner or later, the patient is going to die. My treatment as a healthcare professional, make sure that the patient is enjoying the rest of his life symptom-free. That is when you do the opioids, but very cautiously. not only to help with the symptoms to decrease the pain and make things like satisfactory for the patient or bearable for the patient. Okay, so refractory dyspnea, we use opioids for palliative. Other than that, it is not required or it's not indicated. Okay, home nocturnal non-invasive ventilation, select chronic hypercapnia again, and recurrent admission. So for this one, it has to be frequent exacerbation or admission. So this one is a treatment. I think I should add a few. Maybe this one. So that you guys know. Yeah, here we go. So as I mentioned that we always start from here. So this is the first, not the first, this is zero stage. Zero stage is self-management, education, smoking cessation, exercise, active life, vaccination, short-acting bronchodilator, PRN as needed. So this is stage zero. If it doesn't help, then I move on to LABA or LAMA. If it doesn't help, I combine them, LABA and LAMA. So stage two is what? Stage two is LABA and LAMA. The stage zero is short acting. Stage two is either LABA or LAMA. Stage two combined. Stage three steroid. Okay. Now, if it doesn't help, then I escalate. If it doesn't help, I escalate. It doesn't help, I escalate. Okay. Now, these are the points in all COPD. If you know this, you're on the safe side. Diagnosed with a post bronchodilator spirometry, not imaging. So it means if you're going after diagnosis of COPD, do not do imaging. Just do the spirometry, okay? Unless this is a COPD, you're ruling out the complications, or you're suspecting that it might not be exacerbation, then you can do imaging, okay? Treat based on symptom and exacerbation, not only based off the FEV1. Remember, we have FEV1 over FVC to diagnose or confirm the COPD. If it is less than 0.70, this is COPD. If it is more than that, it is asthma. So let's say this is less than 7.0. Now, for me to check the severity of COPD, I check the FEV1 weekly. That is to check the severity, okay? They might ask you a question, which one of the following is used weekly to check for the severity of the symptom of COPD? That is VE1, but FEV1, sorry. If you want, like, again, there are two words that you need to pay attention. The best way to find the severity is not only based on the FEV1 alone. It should be the symptoms as well, or the body, BODE, plus the FEV1, right? Which is part of it. So that is the best one. But the commonly used one is the FEV1 and easiest one that's being done. But it's not as accurate as the symptoms with it, as the body, as the CAT and MMRC altogether, which I will show you while we are doing the cases after this lecture. So start maintenance with LABA or LAMA, step it up with LABA plus LAMA, as I mentioned, for the symptoms. And if it doesn't help, then LABA, LAMA, and steroid. Okay, maybe I should add it like this. LABA plus LAMA plus ICS, which is also called triple therapy. So add ICS only when needed. So yeah, this is very important. So we add this if the patient is not improving. If the patient is not improving, again, you have COPD patient, you started the short acting, and this is as needed. You stop smoking, you did the vaccination, you did the exercise, you did the pulmonary rehabilitation. Now you're starting the first line of treatment. What is the first line of treatment? This is the first line of treatment. LABA or LAMA. Now the patient is not improving. I'm going to second step. The second step is LABA plus LAMA. Now the patient is not improving. I'm moving to LABA, LAMA plus steroid, which is called triple therapy. Or in some cases, they may give you some clues that makes a steroid an ideal or a typical option for you to choose. For example, they give you somebody with a COPD who has history of asthma, he has wheezing. Not only that, when you check the blood is showing a high level of eosinophil. And also the patient had frequent exacerbation. This is a best choice or an ideal choice to prevent the exacerbation, control the asthma symptoms, control the eosinophil level. Okay. Now, the exacerbation, the target is this, which we did talk about it. Again, we start with this short steroid, antibiotic when the prurulent, non-invasive. If there is hypercapnia and acidosis, when I say hypercapnia, the PA2 is more than 45 and the pH is less than 7.35. Intubate if this fails or contraindicated. For LTOT or long-term oxygen therapy, improve survival only with the chronic hypoxemia, meet the criteria. And what is the criteria? If the PA2 is less than 55. But if somebody who has core pulmonary and polycythemia, it can be still a little higher than that, 56 to 59. Still, they are eligible for the long-term oxygen therapy. Always rule out the mimics, pulmonary edema, pneumonia, pneumothorax, CHF. And thank you very much.